All right. Thank you, Dr. Inazzoni. So next up, we have Dr. Miloslavsky. So Dr. Miloslavsky is a rheumatologist, and he has expertise in vasculitis. He's a member of our program on the rheumatology side, as well as many other areas of rheumatic disease care, and is also an expert in medical education and a very difficult person to beat and squash. He's an associate professor at Harvard Medical School, and we're pleased to have him here today. You can use that.
Thanks so much for having me. When Dr. Wallace invited me to give this talk and said I would only have a half an hour, I said, it's an impossible task to talk about steroids in a half an hour. Maybe we should have a full week conference on it, so stay tuned. I don't have any disclosures, and I really wanted to talk about three things. Kind of put prednisone in context, where we were, where we are today, and sort of where we might be headed in the future. And then spend sort of the last part of the talk really talking about how we could all do better and what we can do to sort of prevent the toxicity of prednisone, because I think we will continue to have to take it, to have to use it. I know a lot of people in this room have some personal experience with this, and hopefully we could have a good discussion in the last part about issues that are important to you guys. So this is a study from the 1960s. So steroids were started to be used in the care of diseases in the 50s. And so this is sort of the first study in what used to be called Wegener's granulomatosis, now known as GPA, which was previously really a fatal disease. And this study showed that if you use steroids, especially for a long period of time, people did better. But in this study of very few patients, they sort of already noted that the complications of the steroid therapy were multiple, inconvenient, and on occasion life-threatening. I think that's putting it pretty well for sort of one of the first experiences with these drugs. I think this statement probably resonates with a lot of people in the room. And this sort of highlights the double-edged sword that prednisone really is. And I think everyone who treats autoimmune disease, not just vasculitis, has these sort of two patients in mind. So this, I have two patients, both in their 50s, both with the same disease, ANCA vasculitis with severe manifestation in terms of lung involvement, nerve involvement, et cetera. And they both got the same treatment. And one, I'm not going to use any real names or pictures. This is a diagram from the internet showing the common steroid side effects. So one got almost every one of these. There was kind of obesity, weight gain, water retention, moon faces, these red marks on the abdomen, easy bruising, and then even more seriously, she then developed diabetes and had multiple infections. So a lot of steroid toxicity. And then basically the exact same patient on paper could have no side effects and be perfectly well. And there are probably both of these spectrums, right? People who have had both of these experiences in this very room. And right now, we can't really tell when we start who is going to be whom. And that's another huge challenge in using steroids in any condition. So why is this particularly important now? So Dr. Inazzoni just gave a great overview of where we're headed in giant cell arteritis. In ANCA-associated vasculitis, another one of the most common vasculitides, in many ways, we're sort of ahead of this, ahead of GCA. This is sort of a timeline from when GPA was first described. And we think of GPA kind of in the same way that we think of microscopic polyangiitis. They are very close cousins and treated the same way right now. And EGPA, formerly Church-Strauss, sort of a similar disease with a slightly different treatment paradigm, but this sort of applies to that as well, that, after prednisone started to be used in the next 70 years, we then had, 5 approved and frequently used medications, actually more. I didn't put everything on this slide. And you could see that, studies came out every 5 to 10 years with a new treatment option. And so now we have many treatment options in this disease, but interestingly, we didn't really start to play around with the steroid part until more recently, right? Really after rituximab, after we had multiple drugs, did we start asking questions, well, can we reduce the steroid doses that we've been typically using? And the answer turns out to be actually yes. And then I'll touch briefly on avacopan. This is a newly approved medication that several people in this room, Dr. Niles in the back, have had played a large part in doing studies on this. Is the first drug to potentially either eliminate or really minimize the steroids we use in this disease. So this is, we don't, in severe diseases that always required high dose prednisone, this is like a huge breakthrough. But we're not quite there yet. And just to kind of echo what Dr. Unizoni said, GCA, not so much, right? Really not many approved treatments. Tocilizumab was the first, but you see the door that opens up and all of the studies that are being done now. And Dr. Unizoni also pointed to the same thing that we saw in ANCA vasculitis, now starting to ask, well, can we use less steroids now that we have effective treatments? So steroids were a necessary evil, but we are sort of entering this new age where that might not be the case. And now more than ever, really understanding steroids, because maybe we don't need them as much anymore, is more important than it ever was. So how do we evaluate whether we should continue to use prednisone and in whom? This is, I think, one of the many questions in our field. This is generally how we think about medicines in general. Do they work? Are they very expensive? Well, I would say that's like the least, the lowest concern, at least to us as treating physicians, but maybe not to the healthcare system as a whole. And then the side effects. Sort of a lot comes down to side effects, and this is the critical issue with prednisone and other steroids. But steroid toxicity is sort of hard to evaluate. We all know the side effects they cause. We've all seen it. Many of us have felt it. This is the GIACTA study that Dr. Unizoni just highlighted. This is the study that led to the approval of tocilizumab. These are sort of the efficacy curves demonstrating that when you take tocilizumab, you do better. You have less flares. But when you looked at toxicity in this study, the side effects, the actual total side effects were equal, even when you took less prednisone. Right? Really unexpected. Now, when you looked at some of the serious side effects, maybe there were numerically less in patients that took Actemra, and there are other studies like this where it's sort of counterintuitive. You introduce a drug that you think is going to get rid of prednisone, and you expect the toxicity to look much better in patients taking that drug, but on paper, it doesn't look as good as you would think. And why is that? Is it because these trials are enriched for that second type of patient that doesn't have a lot of steroid toxicity? Or is it other things? And so these studies often end up reporting outcomes like this. Patients took less steroids. They took 2 grams less prednisone over the course of 6 months. But does that really answer our question about, is it worth it? Just reporting doses of prednisone saved is not really a great outcome measure. So this is kind of where we are. So I want to spend a little bit of time, and this is me kind of nerding out a little bit on, well, how can we do better? How can we understand steroid toxicity better? Because understanding steroid toxicity better will help us understand the value of these new drugs better. It would help the FDA make better recommendations on what drugs we should be using and for how long. So these are some of the problems and why steroids are hard to study. For example, this issue of attribution, which just means that if you develop high blood pressure and you're on prednisone, is the high blood pressure from prednisone? Or are you like millions of other Americans that will develop high blood pressure because of other factors? Can't pin everything on prednisone, even though we would like to. And so how do we solve that? And one way to solve that is study these randomized trials that Dr. Unizzoni was just highlighting. Because when you have people randomly assigned to 2 treatments, and one of them is prednisone and one of them is not, you could look at the difference in how frequently people develop these side effects like high blood pressure. Then there's this, you would think that a trial would capture all of the side effects that happen, right? But that's actually not at all the case in real life. If you don't say what toxicities you're looking for, they're much harder to capture. Just like, you know, when you, I don't know, look at art or go out birding, you have to look for it. It's not just gonna like be apparent to you. And then, you know, there's so many steroid toxicities. Are they all the same? Is a skin bruise this obviously not the same as a severe infection, right? So how do we weigh them? And I will say that not surprisingly, how much these toxicities mean to different people is actually quite different, right? We all have different values and different preferences. And then a lot of these trials are enrolling patients that have already had this disease before, they've been on prednisone before, and now they're having a relapse and have to get treated, right? So how do you account for the fact that some people already have steroid toxicity coming into these trials? So you could see how complicated this is. And these are some of the potential solutions. Make a tool that allows investigators to look for specific toxicities, study it in trials where the treatment is different, but the patients are the same essentially because they're randomly assigned to 2 different treatments, weigh the toxicities, and then measure change over time. Because maybe people who had a lot of steroids before and now go into a trial where they have taking a medicine that allows them to not take more prednisone, maybe some of that steroid toxicity will actually get better. And so we, you know, several years ago now, 7 years ago, time flies, developed a tool that sort of allows steroids to be studied in this way. And now it's, I think, in over 10 randomized trials and has been studied in other ways. But sort of the first big trial that it was used in, that Dr. Niles and several others in this room were involved in, was avacopan, which I mentioned before, which is now FDA approved for the treatment of ANCA vasculitis, specifically GPA and MPA. I'm not going to spend a lot of time on this, but the study was basically designed that people would either get standard treatment, which was generally rituximab or cyclophosphamide and prednisone. That's how people with ANCA vasculitis were treated for the most part. And then the avacopan group would get the rituximab or cyclophosphamide and the study drug, which was avacopan, and then be tapered off prednisone really quickly. It's basically a study that in one group you get a lot of prednisone, and in another group you get much less, although not zero. You know, again, one of the first studies of its kind, but now you're seeing a lot of these coming out. Dr. Unizzoni showed this already. So we are in this new phase where we could actually study this. And avacopan did better. Patients on avacopan did just as well as patients with traditional treatment. And on the bottom there are just some of the scores for this tool. And you could see that the higher numbers are people in the prednisone group. And then you could kind of delve into this and see what those higher numbers means. Is it more diabetes, more high blood pressure, more weight gain, more infections, et cetera? I'm not going to show that data because it's a little overwhelming. But now we can do better than just saying patients who took this drug took less prednisone. We could actually say patients who took this drug had less toxicity in these specific ways. And now we could weigh the benefits of these drugs much better. But this is not the end all be all. First of all, this tool is going to evolve, but there's this other side. Well, how do patients see this, right? Everything, you know, traditionally medicine has been very physician centric, and that's changing. But we're still sort of a little bit behind where we want to be. This is a nice study from about 10 years ago where they asked like over 100 rheumatologists and over 100 patients to rate how important various steroid toxicities are. And you can see how, you know, the black lines are ones where there's a big difference between how physicians view things and how patients view things. And then the gray lines are where things are more or less equal, more or less. And I mean, I guess there's sort of good news and bad news here. As physicians, we view these as most important, and most of these were very important to patients, although things like coronary artery disease, which I'll touch on in a little bit, were less important to patients. And then things that we don't even necessarily think of as steroid side effects, although clearly we do, but we don't think they're that important, or these physicians didn't think that they were that important, are really important to patients. So perhaps the next step is really developing a tool like the GTI, but from the patient perspective, because that's no less important. All right, so in the last 5 minutes, I really want to talk about the fact that steroids, I think, will continue to be inevitable, but hopefully less and less. And some side effects, unfortunately, are probably inevitable, but there's a lot that we can all do to prevent possible side effects and decrease steroid toxicity. And it's not easy. You know, it's not easy when you have a new disease, which is very stressful. And sometimes doctors are so busy thinking about, is the disease well treated, that it's hard for us in a short visit to really spend a lot of time on these things that are really important and can help people do really much better over time, and that is preventing steroid toxicity. So I have my top 10 list of preventing steroid toxicity. So here we go. I think it's hard to do all of it, but pick the ones you like the best. I think, and it's in 3 domains. And the first domain is heart health. Because just like most Americans, the thing that harms patients with vasculitis is heart disease, right? Like people almost very rarely die from vasculitis anymore. We hardly ever see that. People get sick from typical causes. But heart disease is more prevalent. It happens more in people with vasculitis than people without vasculitis. And that's in part from the medicines we use, like prednisone, and maybe a little bit from the disease itself. You can imagine that when you have a disease of the blood vessels aren't as healthy. And so you're a little bit more likely to build up cholesterol in those blood vessels and get a blockage in the artery that leads to a heart attack, for example. So this is stuff you've probably seen and heard before. This is things that you should do for your heart regardless of whether you have vasculitis or not, but it's particularly important if you have vasculitis or if you're on prednisone. Diet and exercise. There's so much about anti-inflammatory diets out there. We don't really know which of those actually decrease inflammation, but we do know that diets like the Mediterranean diet are healthier for the heart. And we do know that having lower calories and limiting weight gain is healthier for the heart. So rather than, to me, that's the most important part, rather than thinking about, the specific anti-inflammatory diets. Exercise, sort of obvious, but really hard to do. Hard to do when you're sick, hard to do when you're on prednisone. Starting a little bit at a time, doing something you enjoy, I think it's really important. And then high blood pressure, high cholesterol, and diabetes are all very treatable with frankly pretty safe medications, but you have to sort of monitor for it and be aware of it. And when you're really sick with other stuff, that can be hard to do. So it could be hard to do for a rheumatologist. So, and for you to really keep on top of. So, partnering with your primary care doctor and your rheumatologist to check your blood pressure, check your cholesterol, make sure you're not developing diabetes. And if those things are coming up, treat it, right? And then Dr. Hall is going to talk a lot about stress and sleep, which is also important in cardiovascular health. Infection, something that we fear a lot. Fortunately, this is happening maybe less than it was a decade or 2 ago, maybe because we're using less prednisone, because we know how to use these drugs better, but it still happens, and it's not fully preventable, but it's preventable in part. What can we do? Vaccinate for COVID and other common infections, flu, pneumonia, etc. And then when you are sick, if you have a fever, Or if you think, you have COVID symptoms, testing early so that you could get treated early, right? Whereas maybe a healthy 20-year-old be home with a fever for a couple of days and it's no big deal. When you're taking prednisone, other immunosuppressants, you have vasculitis, it's a good idea to get checked out early. And then if you're going to be on prednisone for a long time, and specifically we use this sort of guide, if you're on more than 20 milligrams for more than 6 weeks, we will often prescribe an antibiotic called Bactrim to prevent certain types of infection. Okay? So there are things we can do. And then lastly, bone health. Prednisone weakens bone, and it often happens kind of earlier on, as a rather, the effect is often in the first year as opposed to like 3 years down the road. So everyone on prednisone, we always recommend calcium and vitamin D. But if you're going to be, another rule here, on more than 7.5 milligrams for more than 3 months, which many patients with vasculitis are today still, although hopefully not for long, then we know that taking a bone building medication that people with osteoporosis take, like alendronate or Reclast, can help prevent osteoporosis. So there's lots of things that are preventable, but you could see it's sort of a lot of work and a lot of things to keep track of. You shouldn't necessarily be responsible for all of it, but it's good to be aware so that you can help your doctors treat you in the most comprehensive way possible. So I'm going to stop here and just summarize that steroids, I think, will remain a really integral part of what we do. They are one of the very few things we have that work really quickly, that are really powerful, and that treat inflammation in a really broad way. But we're definitely in the age where we're using them less. I think for all of us, our goal is to get people off prednisone completely. It's not possible for everyone. There are people whose disease really needs a little bit of prednisone, or who've been on prednisone for such a long time, it can be hard to taper off. But I think our goal is prednisone 0. And our long-term goal, so our current goal is prednisone 0 once you're in remission. Our long-term goal is prednisone 0 all the time. And we're entering that future now. And that side effects of steroids can be prevented, and that hopefully one day in the next, hopefully 10 years, with all of these studies and better tools, we'll actually know steroids better. And maybe we can still use them, but in a much safer way than we have in the past. Maybe we'll be able to tell in that tale of 2 patients that I alluded to in the beginning, who's likely to have side effects and who isn't. So I'll stop here and I'd welcome any questions.
Hi, I'm Liz. And I'm short. What's your strategy for vaccinations with B-cell depleting drugs such as rituximab? Do you play the B-cell game? Or have we learned enough about T cells that we're going to go ahead and vaccinate anyway for things that people need, like shingle shots, COVID shots, flu shots, blah, blah, blah?
That's a great question. I feel like a politician right now because I'm going to dodge this one. But that's because we have a world expert, Dr. Camille Cotton, who can talk about this question a lot. But what I will say is that right now it's a really individual decision, and that's because some people can safely interrupt rituximab, lengthen rituximab, so that maybe, and depending on where you are in the vaccination cycle and time of year, maybe you could be in that window when the rituximab effect has waned, but you don't need another dose yet. Whereas other people need the rituximab effect year-round, and that strategy is different. And vaccination there is still important and still has a role. And Dr. Camille could, Dr. Cotton could comment a little bit more on what you're referring to, which is the humoral immunity, ability to build antibodies, and the cellular immunity, the T cells that fight infection. And maybe that's a little bit less affected by medicines like rituximab. Whew.
Hi, another Elizabeth, but I'm a little taller. So I'm 3 years diagnosed with the GPA, and I'm just wondering now. I'm coming up to, let's see, well, 3 years on rituximab and out of the prednisone entirely. So if I were to have a relapse, fingers crossed, do we hit it then? Is this where you come back with the prednisone?
Right. So this is a great question. And I think this used to have a very clear answer. You have a relapse, need steroids, maybe at a lower dose, maybe for a little bit of a shorter interval than before, kind of depending on severity. Usually what we see in these diseases is that when you do have a relapse, and Dr. Unizoni showed you some relapse rates for GCA, the relapse rates for GPA and MPA are not dissimilar, 2/3 of patients over 3 to 5 years, and that's probably optimistic. So there are some people who will be in long-term remission, but for the most part, we think of these as sort of these chronically relapsing conditions. And it used to be that we always need prednisone. Well, now with avacopan, the answer is not sure. Maybe you could do avacopan alone. Maybe you could do prednisone for a very short time, but you're also getting at a really important point, right? Sort of 2 points. We don't know when a flare is going to happen. We know that if you're treated with something, whether it's tocilizumab for GCA or rituximab for GPA, your risk of flare, while not zero, is really low, right? But we don't know when you're going to flare. So right now, it's this individual decision. How bad is a flare? Do you already have something like visual loss or severe kidney disease from that another flare could really alter your quality of life in a dramatic way, and then you want to prevent that, versus maybe the disease was just headache or rash and joint pain, and that's can be recognized and treated without any horrible sequelae. But the other part of that calculus of do I stop treatment or continue treatment is, if I relapse, am I going to need prednisone? Am I going to need another 6 months of steroids and their toxicity? But if the answer is maybe not, like with avacopan, you could see how the calculus of how long you need to be treated starts to change. So the better meds we have, maybe the less treatment you actually need to be on. That's sort of, a little bit of looking into the future. We're not nearly there yet, but you could see how all this drug development changes things in a really dramatic way. Because if you don't have to be on prednisone again, and in GCA you do, right? And in GPA, probably most people would use some prednisone just so you could get a avacopan, get things under control. But we know 2 weeks of prednisone is not, 6 months of prednisone. There's a big difference there.
Hi, this is Glenn. My name is Glenn. I want to ask you a question, Dr. Miloslavsky. Is there a way to determine or measure for a patient who's on avacopan when they might need prednisone kind of mixed into their therapy? Is there any intelligence on that or any work being done on that?
Yeah, right. It's a great question. So I think the way we think about, does someone need prednisone, it really comes down to symptoms. Right. So if you're on avacopan and you're flaring with, more joint pain, more sinus symptoms, any worsening in your kidney function that's due to inflammation, lung inflammation, that's when you sort of need more. And in the acute phase, the more is usually prednisone. But our goal, as I mentioned before, would be, what else can we use to kind of get rid of that prednisone and keep things in remission? I think vasculitis is really different than other rheumatic diseases. For example, I don't know how many people, know patients with rheumatoid arthritis, but, with rheumatoid arthritis, we can tolerate a little bit of joint pain as long as people are doing well and they're not having joint damage, they're doing everything they want, right? But in vasculitis, the goal is to treat to remission, no disease activity. So it's sort of a different paradigm, right? We really want to eradicate any inflammation from vasculitis. Now, one tricky thing is that vasculitis often causes damage. For example, you have like a nerve that's damaged. That nerve doesn't always return to normal. Just because it hasn't returned to normal doesn't mean the disease is active. And it's really the rheumatologist's job to differentiate between active disease that needs to be treated and stuff that's left over, that's disease damage, that you could treat it as aggressively as you want, but it's not going to get better. So that's kind of an important distinction. So I think that brings us to the end, but really wonderful to be able to talk about this issue with so much hope for the future.